Smith, and this is another Surviving the Mayhem. I have to apologize for only bringing you this installment now. It's been a hectic few weeks, but I've got quite a few topics worked out, so hopefully I'll get them to you a bit sooner. For today, I'd like to discuss conversion disorder. I recently rotated through neurology, and it would be a complete waste of opportunity if I did not discuss something neurological, right? So here goes, some short notes on conversion disorder. Now, conversion disorder, or functional neurological symptom disorder, can present with a myriad of neurological symptoms, including weakness, paralysis, pseudoseizures, abnormal movements, and sensory deficits, such as deafness or blindness. Now, it's important to remember that these patients are not faking it. The symptoms are real. Okay, so it's not voluntary production of the symptoms, such as malingering or factitious disorder. It's actually involuntary. And we have to remember that these patients can actually have severe impairment, even worse than their counterparts with organic cause for their weakness. So our attitudes in the emergency department can make a huge difference when consulting with these patients. And we can make a difference by helping our neurology colleagues to identify these patients, to not over-investigate these patients, and to establish good rapport in communicating with them. Now, the next point that we have to make is that, the pathophysiology or pathogenesis of conversion disorder is very poorly understood. The theory has always been that it's emotional trauma or psychological stressor that gets internalized and then manifests as somatic symptoms. So Freudian, right? But this is somewhat controversial. Now, in the DSM-4 and the WHO criteria, initially you needed to have a clear relationship between the psychological stressor and the onset of symptoms. But this has fallen away in the DSM-5 because often we could not find a clear relationship between the two. In fact, our psychiatry colleagues actually did a study and showed that there's no correlation between the psychological stressor and onset of symptoms of conversion disorder. We do, however, know that depression, anxiety, and personality disorders are more common in conversion disorder patients and is more common in females. So a lot of the neurologists that I've spoken to actually said that, quite often you can elicit a history of psychological stress, and specifically in females, look for a history of sexual abuse because that's often present. I think the take home here is that while it would be helpful to get a history of the psychological stress or emotional trauma, it's not always there, so you can't rule it out should you not be able to. Now, the next important point is that this is not a diagnosis of exclusion. I always thought it was. You need to do your CT brain and all your bloods to make sure that this is not, there's no organic cause, but it's actually not. You need to do a proper neurological examination, and in that way you can actually rule out any organic cause for the weakness. And we'll get to that neurological examination in a bit. In fact, over-investigating these patients can actually perpetuate the belief that there's something seriously wrong, so it can actually do more harm than good. Just like over-investigating, prescribing unnecessary medications can do the same thing. So what is the treatment? Communication. It's basically our first line of treatment is education about the illness. And UpToDate has a really nice approach to conversion disorder and the communication that you need to establish with the patient. Now, the first step that they give is to ask the patient what they think is wrong. I think this gives a nice base for you to start with, and it gives you, a clear indication of what misconceptions you need to clear up. Next, they say you need to give a diagnosis. Don't tell the patient that there's nothing wrong with them, because that can really damage the doctor-patient relationship, right? So don't tell them that there's nothing wrong, but give them a clear diagnosis and explain to them what is going on and how you made the diagnosis. So when you go through your neurological examination, you obviously get to come to the conclusion that it is conversion disorder. Then show them. Go through it again and show them, but look, you're holding your leg up yourself, that kind of thing. The other thing is that you need to actually emphasize the mechanism of how this is happening. So, you need to explain to them that there's no organic cause, So the CNS is fine, but there's a problem with your neurotransmitters and that kind of thing. Dr. Kroon from neurology, who you'll meet in a bit, actually has a very nice way of explaining this. And he says, or he tells the patient that it's like a TV. You know, you've got a TV box, which is fine. It's the brain. There's no problem with the brain or the CNS. But the signal going to the TV box is faulty, and that's why you can't get the picture, right? So that's your neurotransmitters. I thought that was a really nice, understandable way to explain it. The other way that you can use is to use computer analogy, where you've got the hardware and the software. So it's not a hardware problem, it's a software problem, you know, that kind of thing. And you have to emphasize as well that these symptoms are potentially reversible. In this way, you know, establishing communication with your patient, establishing good rapport, you can actually have your patient walk out of the ED with no weakness left. The longer the symptoms go on, the more difficult it is, however. And as I mentioned, these patients can actually have severe impairment should they be managed wrong. So how do we come to the diagnosis of conversion disorder? Now, our neurological examination is quite a long one, so I decided I'm not going to talk you through it. I'm going to show you. So I enlisted the help of Dr. Kroon, who is a newly qualified neurology consultant, and Dr. Masinga, who is a registrar from Mozambique in emergency medicine. Now, Dr. Masinga played our patient. He definitely has a fallback career in acting, should the doctor thing not work out, because he played the patient really well, had the abnormal movements, everything down perfectly. And Dr. Kroon was gracious enough to explain everything to us. So let's look at a series of short videos that they were willing to make on the examination of conversion disorder.
Okay, so the first examination that we're going to do is to assess whether the person's got organic facial weakness. So to differentiate that from functional weakness is if you ask the person to close their eyes at full strength, what you will see is you will find what we call the Bell's phenomenon. So the eyes will go upwards. If the person's got functional weakness, the eye will just keep looking straight at you. So let's test this now. Okay. So what this person is coming with, he's coming in with functional weakness now. Okay, so what we do is, so just attach your face, okay? So what you do here is, if you open up the eye, you will see that the eye is looking at you, as opposed to having the Bell's phenomenon, where the eyes are actually going upwards in an organic patient. So close your eyes as strong as possible. So what we look here is, if you can see, give you strong. So as you can see, strong. So you can see the sclera, the white sclera is sticking out when it gives full power. So that will help you to differentiate whether the person is really giving you full strength, or if there's a discrepancy marking the disorder, marking the functional weakness. So next I'm going to just demonstrate the Babinski 2 sign. So what happens here is, if a patient comes in with either hemifacial spasms or with a differential focal aware motor seizures, so what happens in these patients is you're going to do, so with the Babinski sign is, you're going to ask the patients to elevate the eyebrows, and once they elevate the eyebrows, you will see that this movements will disappear. That will mark functional weakness. In organic weakness, this will still be persistent. Okay, so can you please elevate your eyebrows? Okay, so as we can see, there's a quite marked discrepancy between what we had before this happened and now when we're asking to elevate the eyebrows. So you can even make it difficult and ask him to, okay, so elevate your eyebrows and drop it. Elevate the eyebrows and drop it. Elevate the eyebrows and drop it. So as we can see, while we're doing this, the movement is completely dissipating. And this is also marking, this is demonstrating functional weakness or functional movement disorders. Another variation of this is asking the patient to stick out his tongue and then follow with the patient's tongue, they can follow your finger. Okay, so just stick out your tongue for me and then follow it. So if there is organic movement disorders like that happening, the movement will still persist throughout the whole range when we move the tongue, as opposed to functional weakness where this movement will disappear. So here I'm going to demonstrate another movement disorder, a functional movement disorder. Here we have functional tremor. So what happens with functional tremor is, if you ask the person, if you distract them, or you give them something to do, they're going to show entrainment. So this is the hallmark feature of a functional movement disorder is that it shows distractibility and entrainment. So I can demonstrate this by asking the person to tap at a certain frequency or to try to distract them. So let's see. So can you take this hand, and then I want you to tap at the same frequency as I'm tapping. So if I'm going to start slow, and then we're going to go quicker. So as we can demonstrate on his left hand, he's demonstrating what we call entrainment. So the movement is taking the same frequency as my finger tapping, and as well, it's the high frequency tremor is being distracted. Okay, and that also marks the basis of a functional movement disorder. So next up, I'm going to demonstrate the arm drop test. So with the arm drop test, what you see is typically what you're going to do is, if the patient comes in with a hemiparesis or weakness in the arm, and you want to see whether it's organic weakness, you can use the arm drop test. So what you do is you're going to pick up the arm and you're going to drop it over his face. In organic weakness, what should happen is the arm should drop on the person's face. Obviously, you can use your contralateral hand to grab the hand before it touches the face. Indeed, it is an organic disorder. So what happens is with the functional disorders, the arm is going to keep missing the face, like we can see here. And that marks functional weakness because the person's actually controlling is still controlling this arm to see where it's going to fall. And yeah. Okay, so one of the hallmark features of functional weakness is there's a marked discrepancy between modalities of examination. So for instance, this patient comes in and he complains of extensive right-sided hemiparesis. So I'm going to ask him now to move this extremity. So can you please pick up your leg? Can you pick up your arm? Okay, so you cannot do that. All right, but what we're going to do now is we're going to do the Hoover's test. So I'm going to ask him now to elevate the contralateral leg. Okay, so pick up this leg for me into the air. And while he's doing that, I'm going to press down on this leg. All right, and I'm going to press up on this one. So I'm going to test his extensors on this muscle. Remember, this side's extensors is now graded 0 out of 5 power. So please pick up this leg for me, push for me. And while he's doing that, I'm assessing his extensors on the opposite side strength. So pick up this leg, pick it up. So as you can see, he's got a 5 out of 5 power on the opposite, on this weak side, as opposed to a person who have had an organic disorder, which would have obviously elevated the leg if it was truly organic, if there's true organic weakness. I'm going to demonstrate the Hoover's test again. It's exactly the same as the person that was in a sitting position, but now it's in a supine position. So what I'm going to do is, so the patient still has this right-sided hemiparesis. I'm going to ask him to elevate the normal leg. So please pick up this leg, left leg for me. So while he's picking this up, I'm going to assess his power on this leg. So press this hand for me, strong as possible. As you can see, my left arm is assessing his right leg's extensor power. So with this arm, and that's actually giving me a strength of 5 out of 5. Again, that's inconsistent with as opposed to when I ask him to voluntarily move this leg, where he says he cannot move this at all. So there's a marked discrepancy between power, and that's demonstrating that it's actually functional weakness. So another test or examination modality that we can do is doing what we call the abductor test. So what we're going to do is we're going to ask, so this is the person's paretic side, the right side. So I'm going to ask him to flex the leg. So while we keep it in this position, you can see I'm just supporting the ankle. If it was true organic weakness, where the power was 0 or 1 out of 5, when I asked him to move his leg and he was unable to do so, he's actually now keeping the leg in this position, which is at least a power of 3 because it's against gravity. If it was a truly organic weakness, the hip would have gone into abduction immediately when I picked up the leg, as opposed to him who would have kept it in this position. Okay. Okay, so this is another way to demonstrate functional weakness. It's when the patient comes in with paraparesis or lower limb weakness. So what you do is you're obviously going to ask the patient to move his legs. So can you pick up your leg? Any one of your legs? All right. Can you sit up for me? So at this stage, this person cannot even sit up. So this needs to be weakness that's above the T10 level. All right. So what's going to happen now is I'm going to ask him. So this is a modified maneuver. So I'm going to ask him to lift his gluteus off from the bed. In other words, I'm testing his hip extensors. So if he's able to do that, then I'm going to get a power of 5 out of 5 grading, as opposed to a 0 out of 5, which you should be expecting in a patient with organic weakness. So can I just ask you just to press for me your bumps into the air, all right? So as you can see here, I'm lifting up his lower legs, and this is against resistance because of his additional weight as well. So that gives me a power of 5 out of 5 in hip extensors, as opposed to a 0 out of 5, which I should have expected if he had organic weakness. So next I'm going to demonstrate functional visual impairment in a patient. So typically what will happen is if the patient complains of having an acute onset of blindness or unable to see, what you can do is you can perform called the optokinetic test or optokinetic drum test. So it's an app, there's an app that you can download for it just on Play Store or on your iTunes store. So what you do is you can download this. You can also use a scarf in order to demonstrate the same effect. So what you're going to do is, so if you ask the person to look forward, you can either come in with a confrontational approach, but this is a little bit of an insensitive test, because even people with organic blindness might be able to blink because of the air that's moving into the that's causing irritation into the cornea when you do this. Okay, so the other approach then, like I mentioned, is the optokinetic drum test. So what you do is you bring this drum in front of their vision, and what will happen is it will start eliciting nystagmus, as you can see here. Okay, so that means the person is able to still see. Okay, as you can see there, it's eliciting nystagmus. Okay, so then I'm going to demonstrate functional gait disorders. These gait disorders are quite commonly seen in people with functional neurological disorders. So what's going to happen is the typical person will come in. This is demonstrating a magnetic gait. Okay, so as you can see here, this person is actually pressing his feet into the ground, and that's called the magnetic gait, and we see that with functional neurological disorders as well. As opposed to having organic weakness, you won't be able to press your feet into the ground. Next up, we're going to demonstrate the bizarre gait that we see with functional as well, functional disorders. So typically what happens is these patients have a bizarre type of gait pattern, as you can see here. So this is typically, so these patients typically have to use full coordination when they do this, because as you can see here, he's correcting his posture, and he's able to erect himself against gravity. So this is actually this is a nice demonstration of an intact neurological system when this happens. Okay, so what we have here is another demonstration of collapsing or functional weakness. So this person comes in with weakness on the left leg. So what you're going to do is I'm going to demonstrate another abductor sign, so a variation of the abductor sign. So what you do is you're going to ask the person, you first have to test the normal functioning leg. All right, so I'm going to ask him to open up his legs for me. Okay, so open up his legs. So I'm going to give him adductions. I'm going to give him adduction powers. I'm testing adduction strength here. By doing that, I can actually feel this leg is abducting at the same time. So if it was organic weakness, I wouldn't have had this abducting strength. Okay? So then the next test is now I'm going to ask him to open up his left or his weak leg. Okay? So I'm going to ask him to open up. Obviously they cannot do it because they're functionally weak now. But while I'm doing this, I'm testing the strength again. So if it was an organic weakness, this leg would have at least given me some form of strength. But now what happens is I'm getting this collapsing weakness on the normal leg. And that usually means this leg is then functional. There's a functional weakness in this leg.
Okay, so now that we've got our examination done, I just want to do a quick summary on conversion disorder. So the symptoms are real. The patients are not faking it. How do we treat it? Good communication. Don't over-investigate them. Don't prescribe unnecessary medication. And remember that you can sometimes have a history of an emotional stressor, but that doesn't always need to be present. And here's our play out on a little summary on conversion disorder. Hopefully next week I'll bring you something on maybe postpartum hemorrhage, something like that. So bye guys. I hope as always that you survive the mayhem for another week.